Okay, so welcome everybody. Tonight's event is VTE and She, a Women's Health Month event. We're very excited to have you here this evening with us. We are going to introduce you to our clinical guest, Dr. Anna Parks. She is an assistant professor in the Division of Hematology and Hematologic Malignancies at the University of Utah. She's also a faculty member of the Center on Aging, so she is well versed on the menopause question that a lot of us have. Her clinical practice includes the treatment of non-malignant hematologic disorders with a particular interest in thrombotic disorders. She is committed to teaching the next generation of leaders in hematology. Dr. Parks also conducts research to improve the care of older adults with bleeding and thrombosis. She graduated from Yale University, received her medical degree, trained in internal medicine, served as a chief resident, and completed hematology fellowship at the University of California, San Francisco. She completed a 2-year NIH, National Institute of Health, funded fellowship in aging research at the University of California, and received a certificate in clinical research. Dr. Parks actually grew up in Salt Lake City, and she's very happy to be back in Salt Lake City with her husband, her children, and her dog. And I have to say, I'm not sure we've ever had anybody on before who has had so many 5-star reviews from her patients. So that's really quite amazing. Thank you for that. Okay, so before we get going with Dr. Parks, and Dr. Parks, we're very informal. Are you okay if we call you Anna during the course of tonight's event?
Yes, please.
Awesome. Okay, great. So before we get going, just a couple of housekeeping things. We want to remind everybody that we are not here to give medical advice to you. Anna is not your doctor. You need to speak to your own doctor about that. This is for educational purposes only. But we do try to answer as many questions as possible. But just remember, this is an educational event, but you should always speak with your own doctor about your own personal blood clot situation. I am going to turn it over to my PEP partner, Todd Robertson, to read the polling questions and results tonight. And then we also have some resources that we're going to share before we get into it. Okay, Todd, you're up to bat.
All right. Thank you, Leslie. Yes, thanks for being here, everyone. Anna, thank you for being here. This is going to be a great pep talk, a lot of good information. So just a quick poll. We've got 4 questions for you. Most of you guys know how this works, but I know we have a lot of new viewers tonight. Have you personally been diagnosed with a blood clot? Please select your answer from the drop down. If yes to question 1, what type of blood clot? If yes to question 1, was it related to one of the following risk factors? And you can check your drop down. And the final question, if yes to question 1, were you provided with information and resources at the time of diagnosis? We like collecting this data, and we use this information. It's very important. We want to know what you think, what you've been through. So if you could answer those real quick, we're going to read the results and then get back into the program. I'll give it just a few seconds here. All right, so here we go. Have you personally been diagnosed with a blood clot? 85% said yes, 15% no. If yes to question 1, what type of blood clot? Deep vein thrombosis, 17%, PE, 25%, both DVT and PE at 45% and 6% other. And if yes to question 1, what type of blood? Oh, okay, we did that. Sorry about that. If yes to question 1, was it related to one of the following risk factors? Hormonal birth control, 22%. Pregnancy, childbirth, 6%. Hormone replacement therapy, 8%. And no, 63%. And those are the results, Leslie.
Okay. And then I think we just, if yes to question 1, were you provided with information and resources at the time of diagnosis? This is also really disheartening to us that 25% said yes and 63% said no, 11% are not applicable. So we really need to make sure that the clinical community is giving resources to people when they're diagnosed. Okay, and then the only other thing that we want to share with you tonight is we do have some additional resources we want to make available to everybody, which I think is coming up as well here. Here we go. Our new patient resource guide, if you are in the group and you're a new patient, please download this. This is everything that you need to know post-diagnosis, and please reach out to Todd if you're having a hard time accessing it. But here is the QR code. Also, our patient support group, we've actually reached over 7,000 people. As you all know, Todd is the person who leads that initiative. It's an amazing group. I think it might be the only thing on social media where people actually are really supportive of each other, and it's great to see. And then we have a PEP media library that has tons of resources on there that we also want to make available to you, including we have our PEP podcast that we've interviewed a bunch of patients that have had blood clots, and we want you to have the opportunity to hear it, learn from it, share it, and give feedback also, because we welcome your feedback on all of this. And with that, I'm going to turn it back over to Todd.
Yeah, and I just want to say that library of media that we have is amazing. I mean, there are so many topics. I can't believe how many pep talks we've actually done. When I go back in and look at all the older episodes, I'm like, wow, have we been doing that this long? But Anna, thank you again. Thank you so much for being here. Big topic, lots of questions. And I wanted to lead off with something that it's kind of a general question, but it's something that I've always wanted to know about. So I'm just going to ask you straight out, do women actually clot more often than men, or is it pretty evenly distributed? One thing I used to hear is men have a higher reoccurrence rate. If you know anything about that, why would that be? But what kind of data do you have on that?
Yeah, that's such a great question. And I'll just start by saying thank you so much for being here. I really think this is, honestly, it's one of the honors of my career to get to talk to you. I refer so many patients to all your resources, and I know they get a lot, not just from the information, but also from the peer support. So it's so great to be here. So it's actually, it's very interesting. So you're right, that in fact, male sex is associated with increased risk of thrombosis and with increased risk of recurrence. But, and I think this is part of what we're going to get into today, women have these sort of unique risk factors that they face over the course of their life, namely in the form of hormonal exposure in various ways that greatly increases their risk of thrombosis. So that includes things like contraception, pregnancy, the postpartum period. And then we talked a little bit about this. We alluded to this already with hormone replacement therapy. So I think it's a very relevant topic. And I think the poll results kind of support that. You know, there's lots of women who experience clots, and some of them are unrelated to these specific risk factors, but there's these periods that really place women at greatly increased risk.
Oh, okay, well, that's good to know. All right, so we're gonna talk about some of those unique clotting issues now. So Todd, thank you for kicking this off. We're gonna bundle a bunch of questions together for you. So if we lose track, we'll come back to the original bundle. But you know, women do have unique clotting issues over the course of their lifetime, from menstruation to menopause. And so let's start with birth control. So what is it about hormonal birth control that can cause blood clots? And why do some women on hormonal birth control get blood clots and others don't?
Yeah, so this probably is a personal experience for many of you, and it's definitely something that I see in my clinic probably on a weekly basis, which is, you know, a young woman who starts a birth control pill and has a clot, and it comes out of nowhere. She was probably previously healthy, and it's an earth-shattering experience. So it's a very common clinical scenario. And the cause or the relationship between birth control and venous blood clots is actually related to the estrogen in the hormonal contraception. So it's hormonal forms of contraception. And what we found with large studies looking at big groups of people is that it's the estrogen component in what they call combined hormonal contraceptives. And what that usually means is there's a combination of estrogen and progesterone. And the other thing we've learned is that each form, and it's not worth going into the details because, to be honest, most of us look it up too. The other thing that we've learned is that the different generations of these hormonal contraceptives that have different forms of estrogen have different risk of blood clots. Another interesting and important thing is that the risk is, of course, highest when you're first starting a hormonal contraceptive, and then it subsides but remains pretty stable over time.
Oh, I didn't realize that. Why is that? Because you're just introducing it into the body?
Yeah. So that's one of the questions that hopefully you get asked if you find yourself in this scenario, which is like, when did you start? Did you have a change in the formulation of your oral contraceptive? Or did you have a change in the dose? And those are things that should be asked, because if somebody's been stable on a hormonal contraceptive containing estrogen for many, many years, the chances that it is actually related to the hormonal contraceptive, in my mind and in many physicians' minds, goes down, because the risk is so related to the timing of starting.
That's really interesting. Can you comment? We're gonna go off script here a little bit, but can you comment on the different types of hormonal birth control and kind of where they rank in terms of clotability?
Yeah. So really the sort of like old school, older generation contraceptives that tend to have higher doses of estrogen and sort of like older forms are the highest risk. And then as you get towards the newer generations of estrogen containing combined hormonal contraceptives, meaning they have both estrogen and progesterone, they have lower doses and newer formulations, and those seem to connote lower risk of clot. And then, of course, thankfully for us as hematologists, because we recommend them all the time, there are progesterone-only forms of birth control. And I think we're going to talk about this a little bit more. But those forms, for the most part, do not connote an increased risk of thrombosis. So there's different forms, including an oral form, a pill. There's the progesterone-only IUD. There's the progesterone-only implant. All of those are not associated with increased risk of thrombosis. There's a sort of a form in the middle there, which is the Depo-Provera progesterone injection. We try, those are thought to increase the risk of thrombosis. So those kind of exist in between the estrogen containing contraceptives and the progesterone only contraceptives in terms of risk of thrombosis. And then, of course, there's non-hormonal forms of contraception like condoms and copper IUDs, which are not associated with thrombosis.
Thrombosis, right? Okay. So if a woman has a family history of blood clots, does that mean that absolutely she should not take hormonal birth control? Or is that a conversation? Like, what other options are given to women that have a family clotting history?
So this is a really great question and a complex question. I think this does go back to, this is always an individualized decision. But the key thing is that if you or a family member have had a history of thrombosis, that you should absolutely let the prescribing clinician know. Because it is what we call a relative contraindication to getting contraceptives with estrogen if either you have a personal history or you have a first-degree family member. So a parent or a sibling who's had a blood clot in the past. Those things require a discussion, recognizing that the risk in all comers of having a blood clot on a contraceptive that contains estrogen is about between 2 and 9 times the baseline risk. So it's a significant increase, but it's always an individualized decision. And I always bring this up because the risk of clot with pregnancy, for example, unintended pregnancy, is much higher than the risk with estrogen containing contraceptives. So for some women, those are that's actually the best option, but it's always something that you should talk about with your doctor.
So that's interesting. I've already learned new things tonight. So thank you for sharing that. So one of the other issues, and I know Todd, you deal with this a lot in the group over, as the administrator of the group. We hear a lot from women who are on an anticoagulant, and this was my situation when I initially clotted as well, is that they have very heavy bleeding during menstruation. A lot of us were not informed about this, that this was going to be a side effect. So as you can imagine, it comes as a great shock to many of us that experience this. What causes the heavy bleeding? Is there anything that can be done about this? And then when should we be concerned about when it's too heavy? And, what can we do about that? And, we need to take our anticoagulant to prevent clots, but on the other hand, it really does have a quality of life impact on those of us who are menstruating on an anticoagulant. So kind of a lot of questions in there. We can pair them off, but, kind of walk us through that process as well.
Yeah, absolutely. So, I mean, it's just so infuriating that women are dealing with this. I always tell women when I meet them that, they don't have to live this way. But no one has ever told them that. Yes. So, and it's insane because it's about 70% of women or people who menstruate, I should say, experience heavy menstrual bleeding on anticoagulants. So it's not at all rare. And the vast majority of the time, it's very under recognized because the vast majority of the time, they're not super anemic or, like passing out. It's a more subtle process, a chronic process. And they just slowly become iron deficient, which causes this whole host of symptoms, including neuropsychiatric symptoms like depression. It's associated with postpartum depression, anxiety, difficulty exercising, headaches, ice craving, restless leg syndrome. I mean, you name it, and iron deficiency can cause it. So, and the cause is simply that it causes increased blood loss from the uterine lining as it sheds. Different anticoagulants have different risks. So, we think about apixaban or Eliquis as having the lowest risk, and rivaroxaban and warfarin, but probably rivaroxaban, to be honest, at least in the studies that we have, as potentially being the worst in terms of causing the most uterine bleeding.
Most of the patients in the support group say exactly that. I see it more with Xarelto than with any other anticoagulant. Absolutely.
That's fascinating. Yeah. So the anecdotal evidence is always right. But so, yeah. And so, Leslie, to get to your question about when is this concerning? I mean, I would say it's always concerning. It's always something that you should be warned about because it has just such a huge quality of life impact. And I would say, at least among sort of, the hematologist circles who treat thrombosis, there's this growing movement towards an understanding that every person who menstruates should get a ferritin at some point during their treatment and early on. And what is a ferritin? That's a marker of stored iron. And if they are low, then they should absolutely not only get treated for that low iron, but also talk about potential ways to slow down their periods while they're taking anticoagulants.
And how would they do that?
Yeah, so that's always a long conversation because there's different options, which is great. So the kind of like old school way was to interrupt anticoagulants. We really try to avoid that because just like you were saying, it's this very distressing thing to be told like, hey, you need to take this for the rest of your life, but don't worry, you can hold it so that you don't bleed to death.
Right.
And we know that that's not a good strategy because we have some data now to show that actually can cause like maybe potentially a rebound thrombosis. And so we really avoid that now because we have lots of other good options. So the first is to think about switching to the anticoagulant that has the lowest risk if that's an option. But we know in real life that's not an option for many because of insurance or other issues, like you need to take a once a day drug, for example. Or going down to half dose if that's an option for you. But then among the other options, so actually first line is hormonal contraception. That is the most efficacious. And again, we try to steer toward progesterone only options. We love the progesterone only IUD because over half of women have no periods at all with the progesterone only IUD. And you don't have to remember to take it every day. And then the progesterone only pill, is another good option. The downside of that, and I think we were going to get to this later, but the downside of that is you need to take it at the same time every day for it to be effective as contraception. But it's effective as, you know, to control periods with it can be a little more liberal. But this is also a case on a case-by-case basis where there are some women who need estrogen combined hormonal contraception to control their heavy periods. And actually the field is really moving towards that being an acceptable option as long as you're on anticoagulation, because
I think this is really important because, you know, for a lot of us, we're told you can do this, you can't do that. And so now there's a lot more data. Have conversation and make sure you have the right doctor, which is hard, but have a conversation about maybe you can tweak some things here. And it doesn't have to be option A or option B only, but there's some opportunity to move things around a little bit. So that's great to hear. And also, I think it's really important what you said about, you know, the iron issue, and that perhaps people should just people should be getting it automatically. You know, that was not the case with me, and it really brought me to a very bad place physically, because I was so iron deficient before I was finally treated. So this is also really great to hear. Okay, I think with that, I'm going to turn it back over to Todd so we can continue this conversation. And Anna, I'm learning so much already from you tonight. This is fabulous.
Good. I just want to say there's like two other options. So if hormones are not your thing, you can take something called Lisata or tranexamic acid, which is a clot stabilizing medicine, and you just take that during your period. And then there's always the option of surgical interventions, but we usually save that for down the road. So I just want to bring that up because there's a lot of women I see in my clinic who are no way, no how, never going to get near a hormone again. And that's totally an option. So not.
Yeah. I think we're going to have another mini PEP on this topic because there's so much that we're learning that we want to share with people. And so definitely we're going to have you come back again. And I also just want to mention that I know you're on our Council of Emerging Researchers on Thrombosis. And we're working on a survey on heavy menstrual bleeding and anticoagulation. So we will be sharing that with people probably in the next few days, because this is such an important topic, and we need to make sure that the clinical community is aware of it. And there's no better way for them to become aware of this than by the patients telling them this is an issue. So, Todd?
100%.
Yeah, and you touched on this a little bit, but you know, you've talked about estrogen being a cause of blood clots for those that take hormonal birth control. There's now a new daily oral contraceptive called Opill, which only has one hormone, progesterone. Reportedly, it's estrogen free. Can you comment, and you did this a little bit, but can you comment again on progesterone only birth control? And is this something that women who either don't want to take or can't take estrogen-based birth control might want to consider? And I was going to ask you, this is really a conversation for the OBGYN or the hematologist, right? And that's probably pretty obvious. That's who they need to have the conversation with. But any comment on Opill?
Yeah, I mean, I think since we've talked a little bit about it already, I'll just say there are clinics out there that are a combination of a hematologist and an OBGYN where you can go and basically get your contraception and get this issue discussed from a multidisciplinary point of view. And I'm sure the PEP groups and the Facebook group can hook people up with resources for those clinics. I think that's a great option for folks to have all the options presented to them, and then you can pick in a rational way and get it that day.
Yeah, so that is definitely something that we want to share with people for sure. And we're not here to promote Opill or anybody else's product, but we just want to make sure that, again, people have the information available to them so that they can make informed decisions with their physicians.
Yeah.
Okay, and we're gonna move on now to yet another topic for women, and this one is a very critical conversation. It's pregnancy-related blood clots. So again, let's start the conversation about why are women prone to clotting during pregnancy and post-pregnancy. I think up to 3 months now post-pregnancy, according to the CDC. So walk us through that, why that is, and what women can do to protect themselves. I know you had a baby recently, so I'm sure this is near and dear to your heart, or lungs, I guess. depending upon the body part, but this is something that, you've dealt with personally to have to make sure it did not happen to you.
Yeah, definitely. I mean, it's sort of an example of how nature is really incredible, but sometimes it goes a little too far because, for millennia, what women died of during childbirth was bleeding. And so the body's natural response to pregnancy is to really try to rev up the clotting system to prevent that from happening. But unfortunately, that can tip over sometimes. And so you're exactly right that it's definitely present. Essentially, we think from conception onward, but as pregnancy progresses, the risk goes up. And then you're just as you said, Leslie, the postpartum risk, so after the birth, is actually the highest risk time period. And that's probably from a biological perspective because that's when most postpartum hemorrhage happens. So that's when the body really tries to, prevent that from happening. And then secondly, because we all know there's things that potentially increase clotting risk that occur around the time of childbirth, like C-section or surgery, for example. And then, it's your body's going through something huge. So of course, like people are a little more immobile around that period, et cetera. So I think I think a really important thing for people to be aware of is actually there are guidelines from the OBGYNs that certain patients, even who don't have a known history of clotting disorder or like an inherited thrombotic disorder, for example, there are some patients because of the circumstances of their birth that should get preventative blood thinner after delivery. And they may not be getting it. So it's a good thing to think about and ask about. And then being aware of early symptoms of clot in the pregnancy and postpartum period. For some reason, pregnant women seem to get clots on the left side more often than the right. That's probably anatomic from the way the uterus sits on the veins. So that's one thing to be aware of, but it can be really hard because everybody's short of breath when you're pregnant and your legs swell, and it's hard for patients. It's also hard for doctors, but everybody needs to have a really heightened awareness.
Yeah, for sure. And you raise a really good point about C-sections because you see this more and more. That's major surgery, and major surgery is obviously a risk factor. Your body is already in a hyper state of, coagulation. So I think that's really important. And for Black women in particular, we know the statistics are even worse. I think according to the CDC, they say it's the third leading cause of maternal mortality in this country for Black women is actually blood clots. So a very scary thing that's preventable. So again, need to make sure you have that multidisciplinary conversation with your healthcare team. Well, we're glad you're okay and you did not have a blood clot when you had your baby recently.
That's for sure.
Thank you. Yes.
So, we have a lot of women who have had blood clots and they really want to start a family. And, let's just go over that again too. What do they need to know? And I see a lot of patients coming into the group, and these are young women and they want to start a family. They want to start having their life built, and they're very worried about it. But, how should they go about this? Who needs to be a part of their medical team? Do they need a high risk OBGYN? Can they be on a DOAC, or do they need to transition from the DOAC in advance of getting pregnant, like we were talking about, to Lovenox? But who really needs to be on that team, first of all?
I love this question. It's so thoughtful. And I know this is, I mean, it's anxiety provoking to get pregnant, even if you don't have this extra thing to worry about. So what I always tell women is, and people who want to get pregnant is, if you want to have a baby, we can help keep you safe. That's our job. But I do think that advocating for yourself and making sure you have a team who is well-versed in this clinical issue is super important. And there's nobody more important, to be honest, than the high-risk OBGYNs. Because really this is where they shine, because they do see this all the time. And they're just very well versed in basically managing anticoagulants around the time of conception, around the time of delivery. And of course, hematologists help, and we do all the time. But I think seeking out that care really will help you feel much safer. In terms of your question about DOACs, so what we tell folks who are trying to get pregnant is totally fine to stay on the DOAC until you get a positive pregnancy test. And then we switch them right over to Lovenox.
Okay.
And that's because, like many things during pregnancy, we just don't have a lot of data about DOACs in pregnancy. But there is some suggestion that it could potentially cause birth defects. And so, of course you have the option to switch to Lovenox as you're trying, but we do definitely recommend switching at the time of conception. So as soon as you get that positive pregnancy test, Lovenox and unfractionated heparin, or so enoxaparin and unfractionated heparin, are well known to be safe both during pregnancy and during breastfeeding. So that's generally what people stay on for up to 6 weeks postpartum, depending on the clinical situation, particularly if they want to breastfeed. If they don't want to breastfeed, then you can switch over to a DOAC pretty soon after delivery.
Okay. Great answers. Great answers.
So you said they stay on it for 6 weeks post delivery, but they're still at risk for a blood clot for 12 weeks. So you've got that additional 6-week period added onto it.
Yep. And so that's, honestly, that comes from the guidelines. So, and those guidelines are based on the best available data that we have, that the risk benefit ratio, the clotting risk, although it's still elevated up to 3 months, and there are certain patients who do stay on out to 3 months. But the majority, and again, it's also not everybody who's on for 6 weeks postpartum. This is where you just need to talk to your experts. They need to know all of the clinical details. But yes, in general, it's 6 weeks because it's still elevated, but seems to subside at the 6-week time point for the majority.
Okay. So a lot of folks that are with us tonight, they know the signs and symptoms, and we say we're always sharing signs and symptoms. What in particular should people be focused on during pregnancy or post-pregnancy so that they're aware of potential blood clot? I know you talked about shortness of breath, but are there certain things that they should pay more attention to? I mean, obviously all signs and symptoms, but are there any things that you see on a more regular basis? And is there any benefit for women to wear compression socks?
Such great questions. So yeah, I think you're right that if anything is bothering you, just go get checked out. Have no hesitation. And I want to reassure pregnant women too that there are safe imaging studies that we can get during pregnancy that don't expose your baby to radiation. So don't let that hold you back. Oftentimes we'll get an ultrasound even of the legs, and then that gives us our answer. So just as a quick side note to that.
Also important to share, yeah.
So I think, anecdotally, what I'll say that people kind of like push aside and maybe don't bring up because they think they're out of shape or, what they're just like still recovering, is that like unable to exercise in the way that they used to be, or they feel like tachycardia or fast heart rate with exercise. Those are subtle symptoms. And of course, it overlaps so much with recovery, but it's something to just be aware of, and don't hesitate to get checked out if you feel like you're not back to your normal self. And then it's the standard signs. I think you're exactly right. So asymmetry in the lower extremities is one of the big things, because a lot of folks have edema or swelling of the legs. If it's uneven, that's more concerning, of course. And then I think sometimes people forget about like lightheadedness and passing out. And again, there can be many reasons for that, but I think that's another really important symptom and is important to get evaluated sooner rather than later.
Okay, good to know. And the compression socks, you recommend them?
Yeah.
Recommend them?
Compression socks are tricky. There's no harm in wearing them. Let's put it that way. Lots of people find them comfortable. They help with swelling that's not from deep vein thrombosis. To my knowledge, there's not any definitive data to show that they prevent blood clot.
Right.
But they definitely don't harm. They definitely cause no harm. And so the same is true for, after a deep vein thrombosis. So I always tell patients, if you feel like it helps you and you're more comfortable, then go for it. But don't beat yourself up if you can't like roll those really tight stockings all the way up to your thigh.
I think people like that security blanket, like if they go on a long flight, even if the data's not there, it makes them feel more secure. And that's really important mentally, right?
Totally.
And I wasn't a big believer in compression and prevention either, but after this last blood clot, which was my seventh. It was a DVT. It was the first one that caused pain and swelling all the way up my thigh. And so for the first time in my life, I used compression. And I am so glad I did, because in like 2 or 3 days, the swelling was down, the pain was gone, and the compression helped control that. So I'm very grateful to compression when it comes to that. So yeah.
That's awesome.
And you weren't even pregnant.
I wasn't even pregnant, and I still had to wear compression.
And a quick question for you, because you've mentioned a couple times the guidelines. And so for those of us that are lay people, what are the guidelines? Because, you know, we all want to educate ourselves, and we're certainly not, you know, doctors the way that you are, but I think people should have the option if they want to, you know, read the guidelines and better understand what's being recommended so they can converse with their clinician more. So in this case, who produces those guidelines? What are they?
That is such a great question. I'm sorry I didn't say it earlier. So most of them, the ones in the US at least, should be free and available online. So the big two societies that put out guidelines for blood clots are the American Society of Hematology. And they have a bunch of different ones, including a pregnancy specific set of guidelines. That covers things related to pregnancy, the postpartum period, and a little bit about other like hormone replacement therapy and contraception. So that's a great resource. They have, you know, the full guidelines where it's like, even I can't understand it and can't bear to read it, but they also have like summary PDFs and booklets that are available on the website. But what they are is, and it's important to know that, you know, these are what we follow, but they are a group of experts who sit down and periodically review all the data on a certain topic, or as much data as they possibly can, and try to, we say in medicine, put their nickel down. Just say, here's what you're gonna, or here's what we recommend based on what we know, which we acknowledge is imperfect because it'll never be perfect.
Yeah.
And so then it gives recommendations you can read, basically like how strong that recommendation is. And that's based on how good are the studies that lead to that recommendation. So then the other big group of guideline makers is CHEST, which is the American College of Chest Physicians. So those are the lung doctors. And those, they actually overlap a fair amount in terms of their recommendations, but CHEST doesn't have a pregnancy specific one. And then the last one to be aware of is the OBGYNs have their own sets of guidelines. So those are the ones that the OBGYNs follow in pregnancy. If you go to an OBGYN and a hematologist, you'll see that there's some subtle differences in those guidelines. And what that just tells you is that that's because we don't have good enough studies to answer those questions definitively. And so you and your doctor can have a shared discussion. That's what it should be.
Can I just ask what doctors are a part of CHEST besides maybe a pulmonologist, which is, I mean, pulmonologist is the lung expert, right? Is there anybody else a part of CHEST?
Yeah, there are also some like internal medicine doctors who specialize in thrombosis that are part of CHEST. So actually the lead authors for those guidelines are internal medicine doctors or hospitalists who see patients in the hospital. Because those folks are, you know, really knowledgeable about anticoagulation as well.
Right.
And thrombosis as well.
Okay, thank you.
Yeah, no, that's great. And it's great for people to be able to do their own research if they want to.
100%.
Yeah. Okay, so we're going to transition over now to menopause and hormone replacement therapy. Before we start talking about that, I just wanted to let everybody know that there's actually been a bill that has been introduced by about 17 female senators, a menopause bill for the first time ever. And we'll see what happens with this. But we were in DC last week meeting with some of these folks saying that, hey, you got to include blood clots, hormone replacement therapy in the menopause discussion. So they were very open to this. And so hopefully we'll have a seat on in the table. But the important thing is they're actually bringing a bill forward for the first time ever, because menopause is a real thing. And there's a lot of clotting issues around this. And you know, there needs to be more research focused on women's health overall. So just wanted to give everybody a heads up on that bill.
And good work on you and the rest of the NBCA team you've been busting butt there in DC. I just want you to know that I appreciate it, and I know everybody else does too.
Thank you. And we will definitely share information about this bill as it moves forward. I think Halle Berry is their spokesperson on the bill, so that helps at least, get some notoriety associated with it. Okay, so let's talk about menopause. This is also, I would say, Todd, one of the big areas for folks in the groups
It is.
dealing with this issue. So again, Anna, talk to us about HRT. Is it our friend estrogen is back? But again, it seems like there's a little bit of a movement towards maybe it's not simply yes versus no in terms of, how women can be treated with regard to HRT. So kind of walk us through that, and then let's talk about dosing also. Again, full strength versus maybe there's some other things to do, maybe there's some other options, and who's in that conversation?
Yeah. So this is definitely something that's changed even since I trained, because I think, even 5 years ago, the thought was that, never under any circumstances would you give somebody who's at risk for clotting hormone replacement therapy. And, I think some of that was probably biased because a lot of times what we use estrogen for in women who are menopausal is to treat symptoms. But, I think if a man had if a man had those same symptoms, there would be no question about treating them.
Yeah.
So it's kind of thought of as like superfluous. But I think there have been a lot of studies to look at alternatives to estrogen for menopausal symptoms, and they haven't been as promising yet. I'm sure someday there will be something, but there's no panacea or silver bullet yet for that. So with that background, so I think the field has really moved, and that's because there's more data now to show that actually it's both dose related, Leslie, and formulation related. So there was a big study looking at thousands and thousands and thousands of women who were on hormone replacement therapy. And it turns out that the risk really seems to be strongly related to oral estrogen. So the pill form of estrogen, because the patch seems to have it has in that big study had no association with clot. So many of us feel quite comfortable with prescribing transdermal or patch estrogen with no qualms. If there ever was a qualm, I still would feel pretty good about an oral formulation. I would try to use the lowest dose and favor either the transdermal formulation or like the topical vaginal estrogen for localized symptoms. So yeah, agreed. I think this has changed. And this is a place where I think there's some variation in terms of how up to date people are on this topic. So it's really important for people to come prepared to ask questions.
What about if you're provoked versus unprovoked?
Yeah, it's complicated. So I still think, that large study didn't necessarily have the level of detail to be able to say, is it safe in provoked versus unprovoked? But if there's somebody that I'm concerned has a very high risk of clot because they're unprovoked or have had recurrent clots or, whatever the situation may be, there's always the option to combine it with anticoagulation. If, for example, you're off anticoagulation, you could restart while you're on hormonal contraception. And, I think most of us would probably, there's some shared decision making that can occur. It's never a yes or no in this situation.
Yeah, this is really important. We definitely need to have another pep talk on really this whole concept of changing the dosing, that again, it's not, option A or option B, but maybe there's something in between. So that's great. We're gonna transition again over to yet another topic that's really, really important that Todd's gonna kick us off with. But I've learned so much from you tonight. This is really fascinating, and Todd and I always take away so much information from, people like you that come and share your knowledge with us. So just thank you. This is great.
Oh, these questions are so great. They're so thoughtful. So keep them coming. I'm ready.
Good, because when we finish with the next part, we're going to go to our round robin. We're going to try to get
Okay.
people's questions answered. So Todd,
Yeah, a
I'm
lot
gonna-
of questions have been coming in. We're going to try to get to many as possible, but I do want to transition to something that is a real issue. And I've seen it firsthand in the support group, and I've seen it firsthand in person when I've went with friends to the doctor, female friends, just being there trying to give them some support, and I've seen this firsthand. But gaslighting of women is a real problem right now, and I think it's been a problem probably forever. And it's getting worse. It's a real issue, and like I said, many in our group have experienced it. Women and minorities are getting gaslighted left and right. And I'm seeing posts come into the group, and there were a couple of days there where every other post was something that was related to gaslighting. And I know Leslie and I have talked about this a lot, just how much we actually see this. And I mean, I was gaslighted a little bit, but nothing to the degree of what I see women going through. And it's really frustrating, Leslie. And we've talked about this so many times.
Yeah, I know there was a post recently where one of the women in the group said she had gone to the emergency room and she tried to explain to the doctor that she had a blood clotting history, and he said, "You have factor 5," and she said, "No, I have factor 2," and he said, "No, you have factor 5," and she said, "No, I have factor 2," and he said, "No, you have factor 5. There's no such thing as factor 2," and she was like, like, how do you argue that point with somebody? It's really, really difficult. So I was really angry when I read that, and nobody should have to go through that. This happened to me when I had my blood clot with my first hematologist. So it is a really big issue, and it impacts the physical and mental health of women having to deal with this. So we want to highlight this topic. We want to bring this to the clinical community. We're not going to put up with this anymore. And we're going to work towards raising awareness on this issue. But, you're a woman, you're a clinician, speak to us on the other side of the table. I mean, you're kind of in two buckets. And so talk to us about, what is your view on this topic? And, what do you tell a female patient who maybe has experienced this? And do you talk to your male colleagues about this?
Yeah, I mean, I'll say I feel like I can empathize, but I can never understand what you've been through having lived through a blood clot. And one thing I always tell my patients is that there's all these support groups for cancer survivors. But when you look at the data, the emotional toll of being diagnosed with a blood clot is actually quite similar to being diagnosed with cancer. But that's totally under-recognized in medicine. And if Serena Williams can get, no one believes Serena Williams when she has a blood clot postpartum, like it can happen to anybody. And so, I wish I could, I think I think acknowledging the emotional toll that this takes, and that is made worse by people not believing you, people thinking your symptoms are from something else, or it just even taking time to get to a diagnosis. All those things are incredibly distressing, and there can be really hard to understand until you've been through it yourself. You can't teach empathy in med school. You can try to select students who show empathy, but it doesn't always, it doesn't always work out that way. So finding communities like the National Blood Clot Alliance, I think, is super important. I do think, I hope, I'm definitely not an apologist for my profession, far from it. But I really do think that there is, I think, a growing awareness that this is not okay, that we need to listen to patients, especially women, believe what they're saying, that shortness of breath is not a panic attack or like a psychiatric issue. I think that I hope, and I really do think that the tide is turning, but it takes stories from patients to help make that happen, and advocacy and education. You know, people are human and they can learn, but it just takes a lot of effort and time. And so I think that there's lots of, you know, junior hematologists and senior hematologists who are trying to move this field forward, but I think we're really helped by patient advocates. There's no way we could ever communicate as well as you do about the experience of not being listened to.
You know what I've always said is if the doctor suffered a blood clot, he'd be singing a different song.
Totally.
Right? It'd be totally about face. And I see a lot of patients in the group lately that have been complaining about, you know, they're not getting the support that they want from home either. Right. So sometimes the doctors aren't listening to them. And sometimes because they look, you know, you look okay a lot of times when you're a clot survivor, unless you've suffered a blood clot, you don't know what's going on with that person. You're not in their shoes, but some of them get no support anywhere. And it's really, really hard on them mentally. We see it all the time in the group.
Oh yeah. I mean, my first hematologist told me that I needed to calm down. And I was like, calm down. And, you know, I didn't say anything because I was like, you're dealing with such a traumatic event that's happened to you. And, you know, I eventually fired him as I started to like get more information and learn, you know, more from NBCA. And I was like, this does not work for me. And so I fired him, even though he was like a very well-regarded, you know, big name hematologist. And I went to a woman who just, it was like night and day in terms of her approach, answering all of my questions and concerns. So we're going to, you know, continue to shine a light on this. We're going to ask people, we're going to have some, we're going to have a poll question about this before we leave tonight. We're going to ask people to share their stories about this with us. So NBCA is going to make this a focal point moving forward because we want to make sure that nobody experiences this, but it is a real thing. And I guess our ask of you, Anna, is in your clinical community that you share with other doctors and say, hey, this is a real thing. I'm tied into this patient advocacy organization, and you know, they see this on a day-to-day basis. So with that, we're going to go to the good part. I hope everybody stays on because we've got a ton of questions. Todd, do you want to kick it off?
Yeah, and a lot of these, Anna, are general questions. They may not all be related to pregnancy and hormones and all that stuff, but a couple of that pop up a lot is like this one: living on blood thinners for life, is it really needed? And of course, that's going to depend on their situation, but what other secondary effects can somebody, you know, besides the bleeding and the risk for bruising and things like that, what else long-term could pop up with someone that's on for lifetime like me? And is it true that it affects the kidneys?
Oh, so these are great questions. So yeah, you're exactly right. Whether how long you need to be on a blood thinner is so dependent on like all the details of what happened to you. So I really encourage you to make sure your doctor asks you every single invasive question about what was going on at the time of your blood clot to help make that decision. So, you know, most people these days are taking direct oral anticoagulants or DOACs. And those have been out for, you know, about 10 to 15 years now. So we have about 10 to 15 years of data to tell us what the long-term effects are. And I always tell patients that, you know, we can study this as much as we want, but you can have any patient can have any side effect that they want on a drug. It's very individual. People react very differently to medications. But looking long-term, I have to say, these drugs are fairly safe in terms of their long-term safety profile, especially the DOACs. They have much lower bleeding risk than warfarin. And, you know, there are, you know, certain side effects that pop up, but in terms of like impairing your organ function and cognition and things like that, we haven't really seen that come out. And these are some of the most prescribed drugs in the world now. So
Yeah, right.
if it were real, we would, or, you know, if it were very common, that's what I should say, it should have shown up by now. Warfarin does seem to have, especially in people with impaired kidney function, it can worsen kidney function over time.
Okay.
Due to some calcification. But to be honest, we have not seen that to the same extent with the DOACs.
Okay, thank you. Leslie, you're up.
All right. Are transdermal bioidentical hormones considered a risk factor? Also vaginal Premarin, followed by please say no, but
yeah, okay. I'll be totally frank. I don't know the difference between bioidentical hormones and the synthetic hormones. So I can't answer that question, but that is a great question for the OBGYNs. But what I can say is that transdermal formulations seem to be much safer than pill, like we were talking about. And so I would feel much safer with a transdermal preparation, but you would have to check with the OBGYNs about the form of estrogen. And then vaginal topical estrogen, same with transdermal, does not seem to increase the risk of clots. And so I would feel totally safe using that with very little systemic absorption. So go for it. I'm going to say no for you.
Okay, great. Todd, we'll ping back and forth, yeah?
Yeah, back to an anticoagulant question. The chances of a clot being on blood thinner. My doctor says I'm covered. I'm on Xarelto 20 milligram, and I have factor 5 and a stroke.
Sorry, can you say that one more time?
Yeah, what's the chances of suffering a blood clot while you're on a blood thinner? And this person has a clotting disorder and has also had a stroke already and is on 20 milligrams Xarelto.
Got it. So again, this is super dependent on like what exactly was going on around the time of your clot, because if your clot was what we call provoked, meaning like it was from surgery or a broken bone or a trauma, the risk of recurrence is very low. But if it was unprovoked, regardless of inherited clotting disorders, we know that that is much higher risk of recurring. But the beautiful thing is that being on a blood thinner like Xarelto is very protective against blood clot. It's at least 80% and probably 90% or more effective in terms of preventing recurrent blood clot. So you can feel very safe. Of course, there are going to be times where people have blood clots through anticoagulants, and that's definitely a time where you should see a hematologist with expertise in thrombosis, because you should have an investigation as to why that happened and how to keep that from happening again.
And whenever we're on this topic, I just have to throw out the reminder, because noncompliance is an issue with anticoagulants, and you've got to take them properly. You have to be consistent with it. You can't be missing doses. This is just one medicine that you need those levels in your system. So you got to be compliant with it. So just make sure you're taking that stuff right.
Which is what I'll be doing after our PEP is over.
Yeah, me too. Me too. Late dinner tonight.
We do not plan this that we take it at the same time. By the way,
I give myself a 2-3 hour wiggle room window.
Is that your nightcap? You take your blood thinner?
Yeah, Xarelto is our nightcap.
Xarelto with dinner every night.
I love it.
Funny. Okay. I have factor 5 Leiden and I'm interested in having children. What type of consultation should I begin seeking? And what are the success rates? So I don't think you can necessarily speak to the success rates, but you can talk to them about what type of consultation they should be having.
Yeah, absolutely. I will just make one comment, which is that it's pretty clear now that inherited thrombophilias like factor 5 Leiden, prothrombin gene mutation do not affect the risk of miscarriage. So I do want to provide some reassurance on that. Fred, that's a topic that comes up a lot for hematologists. It doesn't seem to be associated. So I want to reassure you, I don't think that your factor 5 Leiden is going to prevent you from getting pregnant in any way, shape, or form. And an OBGYN should be able to corroborate that. I would make a preconception counseling appointment with a high-risk OBGYN. And what they do is they go through all your medical history and get you in tip-top shape, answer all your questions, get you started on prenatal vitamins, talk you through all that stuff. With a history of factor 5 Leiden, particularly if you or a family member has had a history of stroke, they'll talk you through the current guidance about whether you should be on preventative blood thinner with Lovenox injections through pregnancy. And so that's the main thing you want to chat with the high-risk OB before you get pregnant.
Okay, good advice. I think, as we come back to another PEP, having you and a high-risk OBGYN together would be amazing in terms of answering patient questions.
Absolutely. There's some great people who actually do thrombosis work within OBGYN who I think would be so thrilled to get the chance to talk to you all.
Yeah, that would be amazing. Todd, you're back up to bat.
Okay, so I had a blood clot 6 weeks ago and I am so fatigued and tired. Is this the Eliquis causing this, or is this just part of recovery and I have to deal with it?
This is such an excellent question. I'm so glad you brought this up. So, and I hear this a lot. So it's possible it's the Eliquis, but what I would want to make sure is that it's not something we call post-PE syndrome, or pulmonary hypertension or CTEPH. You may have heard all those things. So definitely, everybody takes some time to recover from a blood clot. Almost everybody, even like a professional baseball player who gets a blood clot, is going to have some dyspnea and chest pain as they recover if it's a PE, for example. So it would not be surprising to me that it takes several months or several weeks to months to get back to your baseline. But if you're continuing to have symptoms and you're not able to get back to where you were, that is the time to chat with your doctor about whether it makes sense to do some more evaluation for basically strain on the heart and lungs that comes from the blood clot itself. There's no harm in getting an echocardiogram, an ultrasound of the heart, to look for that. And oftentimes we'll get multiple over time to look for improvements. So I would encourage you, so certainly could be the Eliquis, but I wouldn't want to pin it on the Eliquis because that would be a pretty rare side effect. And so I'd want to exclude that other stuff, but totally kosher to see if changing blood thinners alleviates those symptoms if you've kind of ruled out the other heart and lung stuff.
I mean, I've been on Xarelto since 2011, so since FDA approval, right? And it's done a really good job. And I was fatigued and body drained for 6 months after the pulmonary embolism. And a lot of it was that scar on my lung was also making it hard to catch my breath during exertion. But if I had to be patient during that 6 months, everybody wants to feel better in a couple of weeks, and that's usually not the norm.
Yeah,
I usually don't feel that. Leslie?
Well, coming back to the medical gaslighting, it's nice to hear you say that it could be the Eliquis because, a lot of us have hair loss, we're exhausted, their skin is itchy, and we get dismissed right off the bat. And, I don't think you could have that many people who have some of these issues and dismiss all of us. So, it's important that it's taken seriously what everybody is feeling. Okay, so we have somebody who wrote in, they had an unprovoked blood clot in their leg, and actually it ended up in both of their lungs. They're 50 years old. Should my daughters now avoid going on certain types of birth control? That's a great question.
Such a good question. So I think it's definitely worth having a conversation with their OBGYN about the circumstances of the clot, considering testing for specific disorders and then using that to make that decision. But in general, having had a first-degree family member with blood clots tends to sway people away from using estrogen, because there are other good options. So,
So yes.
Yes.
Okay, Todd.
Okay, I've got to ask this one. So you're going to be tested for genetic clotting disorders, inherited clotting disorders. Do you have to come off your DOAC and anticoagulant? Do you have to do that for all of them, some of them? How does that work?
Oh, what a great question. So in general, unfortunately, yes. There are certain tests that we can send on DOACs. So those are the genetic tests like factor V Leiden and prothrombin gene mutation. Those are not affected by anticoagulant, nor are they affected by if you had a recent clot. But for the others, unfortunately, being on a DOAC does affect the results. So there are different ways to skin that cat. Some people will switch to Lovenox briefly or hold briefly. There's different ways to do it.
Yeah, I didn't know. Yeah, so if you're bridging with Lovenox, then you can go ahead and get tested.
Yep,
okay.
Exactly.
Right.
So sometimes we'll do that. Exactly. So if it's during a bridging period, or we'll switch people, or we'll hold very briefly if people are out of the acute phase. There's different ways to do it. I think everybody actually has a different method.
Yeah. Okay. Leslie?
My God, there's like so many questions. It's almost like
multiple pages.
And I'm still here. I'm just moving out of this room because they're starting to shut the lights off.
They're shutting the lights off on us.
Okay. So, and if somebody asked the question about how do they deal with anxiety when coming off of an anticoagulant? What do you share with your patients that come off of an anticoagulant?
Oh, that is very hard. And it's always a long discussion.
Mhm.
So I do try to share like the statistics, kind of what I was mentioning, which is sort of, in real terms, like if you come off a blood clot, how many people out of 100 are going to have another one versus how many people are going to have bleeding if they just stay on a blood thinner forever. Um, and I think those are super important conversations to have. For some people, the anxiety is so much that they just prefer to stay on the blood clot. And I think that's a reasonable decision in certain circumstances. So I think that's an important conversation to have. But I guess what I would say is that you should always take your own symptoms seriously, and and in general, people don't take as long as you're with a knowledgeable doctor who knows about thrombosis, people don't take coming off a blood thinner lightly. And so it's typically done if the risk of having another blood clot is very, very low. And so hopefully that provides you some solace.
Mhm.
Yeah, for sure. Somebody just wrote, be your own best advocate in that. Robin, thank you for that. You are 100%
Totally.
correct. Be your own best advocate, which is hard to do sometimes. So,
Totally.
um, Todd, how about you take one more question? I feel so badly about this because I would just love to keep going with all of these questions, but I know, Anna, you spent a lot of time with us, and you're in clinic currently, so we want to make sure we're cognizant of your time. Really would love to, if everybody on tonight is up for this, we do it like a round robin, type of event, and people can come in and ask their questions and what have you. But Todd, how about one more question, and then we do have a poll question, which we would love people to stay for as well, so we can really focus on this medical gaslighting going forward.
Yeah, so I just want to circle back to the mental health aspect, okay? And that's because as admin of the group, I'm dealing with this with patients all the time. I dealt with it myself. I had to have counseling. You've had to have some patients come to you, right? Just go, I'm just freaking out. I don't even want to go to sleep. I'm afraid I'm not going to wake up. What kind of counseling tips do you give them? Do you have any recommendations? Who should they see? What route should they take? Is there some help for these folks? Because it does help to talk this out sometimes, right?
Totally. Honestly, I don't think I know. And I would love to hear what you all would think is helpful. I think any recommendation I give would be very generic. And so any tips from you guys, I think would be great.
I just know that it helped me to actually see a therapist for the health anxiety because I had just buried my wife who died of brain cancer, and then I started having blood clots. And so it was like death, is it my time? I finally had to talk to somebody. And if it wasn't for that therapist, I wouldn't be able to handle the health issues that I have now. Because I kind of built a toolbox, right? But I needed to talk to a professional. So it's just my recommendation that if at all possible, get a referral to a counselor. There's this stigma around, counselors and counseling that I think is ridiculous. It helps to talk to somebody. So I'm just saying, everybody, if you're out there and you're struggling, try to talk to somebody just besides us in the support group, but see if maybe you can talk to a therapist and they'll help you deal with some of this stuff.
Yeah, I echo that. It was a game changer for me. I had actually never been to one before, and I seem to have fired a lot of people during my blood clotting journey. I fired my first therapist because it just wasn't helping me enough, but I knew I still needed help. And I finally found somebody who was like really fantastic. I know I told a little bit of a fib because I do want to circle back at some point in time. Somebody had asked about IVF and hormonal replacement therapy, which actually we didn't even talk about IVF tonight. And so we do need to come back on at some point in time and address that as well. But any quick thoughts before we jump to the polls?
Yeah, that is its own whole
Yeah.
talk and spiel. So yeah, it depends a lot on the procedures around IVF, the history of the clot itself. So yeah, it probably deserves its own whole talk, Leslie.
Okay, fair enough. Well, we will give it its due mention at a later date. Okay, Todd, let's do the poll question with everybody while we still have folks with us.
Okay, when the poll questions pop up, we still have quite a few people with us. So here you go, folks. Do you feel you have, let me start over. Do you feel you have, that's not even out written right. Have you experienced medical gaslighting? Have you been gaslighted? Yes, no, unsure, or not applicable? If yes, would you want information on how to handle this in the future? Yes, no, not applicable. That is your ending poll. I think that's the only two questions we have. We'll read some results here real quick. Thanks for hanging on and going overtime with us. This topic's just too big to have, you know, just for 1 hour.
Yeah.
Too many questions.
Uh-huh.
And we'll read those to you as soon as they pop up. Here we go. Do you feel like you've experienced medical gaslighting? Yes,
Whoa.
76%. I'm not shocked by that at all. Based on what I've seen, 12% no, unsure 9%. 3% not applicable. If yes, would you want information on how to handle this in the future? 85% absolutely yes, 3% no.
That is absolutely amazing.
Too much of it happening.
Yeah, too much of it happening, and we definitely will be coming back to the community to ask for their help, sharing their stories about this. So be on the lookout from NBCA for more information on this topic. Anna, you were amazing. Thank you so much. I learned so much tonight. You know, we'd love to have you back, and we're going to do a round 2 of this because there's just so much information for us to unpack here.
Oh, it was so fun. Thank you so much for having me. Really, truly, it's an honor to be with you all. And I learned a ton too. So thanks for the thoughtful questions and moderation.
All right. Take care
You're
now.
welcome. See you later.
Bye.
Bye-bye. Bye,
Thanks,
everybody.
everyone.
Have a good night, everyone.